of your friends, if they are interested in preparing for Jan course, this is the course features and course fee. But still there is offer. So if group discount is there, scholarship is there, installment option is there, even 50% or more than 50% discount for the group. So if anybody is interested, you can direct them towards TOG study. So we are starting the topic now. TOG study, as I told you, we have to study smart, not hard. Very important to have a right guidance, how to read the TOG, how to compile it, how to understand it, how to study in a smarter way, not harder, right? So let's start the recent TOG of 2023. The topic is valvular heart disease in pregnancy. 2023 first and second volume is out. First volume have a few important topic, right? Like anticoagulants in gynecology, which is already there in YouTube channel to go through. The YouTube channel is having all the, whatever material uploaded in YouTube channel, believe me, are all important topic for exam. So please go through that. That helps in understanding. It's a short thing. Anytime you can open your YouTube and MRCOG YouTube channel, you can read, go through the topic just in a short while. So valvular heart disease in pregnancy is the first volume, page number 19 to 27, 2023 year, January volume. So what are the key points about the valvular heart disease in pregnancy? Before we start it, anybody has any doubt about how to study the TOG? Any confusion?
Cleared, ma'am.
Okay, thank you. So valvular heart disease in pregnancy is very, very important topic for exam, because heart disease is always very important for exam. It's a medical disorder. It comes under maternal medicine. And most of the time we are not, if we are not working in the tertiary center, we don't deal much with the cardiac disease in pregnancy, right? So they want you to know, because it could lead to mortality if we don't know how to manage them. It could be very detrimental for the patient. So they always ask you question about heart disease in pregnancy, like peripartum cardiomyopathy TOG was there. They ask question from that. Then valvular heart disease. Now the coronary syndrome in pregnancy has also come in the 2023 volume 2. So all these things they like to ask. Once you read, you will automatically understand that what all important topic they ask. Once the talk get fleshed, automatically you understand that some are very advanced topic for super speciality, like infertility specialist or oncology, which is not important for you for exam, because you are an ST5 when you're giving exam. So your knowledge is basic. They don't expect you to be super specialist knowledge like infertility specialist, oncologist, lab specialist, laparoscopy. They don't expect you urogyne. They don't expect you too much deeper knowledge of that, just basic knowledge. So they want your basics to be clear, and they want your maternity to be very, very clear. Because as an ST5 here, we manage the labor ward independently and things like that. So they expect that, but they don't expect too much of supremacy or too much of knowledge of deeper gynae, advanced gynae, because that is what the ST5 is not going to do. That is a super specialization part. So that way we can segregate what is more important and what is less important at that point. So we all know that pregnancy leads to hemodynamically changes in the cardiac function, right? So definitely the valvular disease will make it difficult for the body to handle the pregnancy pressure, to handle the increase in the volume in the body, more blood circulation and more demand of the pregnancy and everything. So what they say is regurgitant valve lesion are better tolerated in pregnancy than stenotic lesion. Why it happens? Because in pregnancy, the vascular resistance decrease, right? So vasodilatation happens. Every pregnant woman is flushed because of the vasodilatation. So regurgitation happens because of the pressure, right? So if the resistance is less, automatically blood can easily flow. So regurgitant lesion, that's why, is better tolerated in pregnancy due to decreased peripheral vascular resistance. Now, once you understand this, in exam, you won't get confused under pressure, because your understanding is clear. Why regurgitant lesion are better tolerated than stenotic lesion? Why stenotic lesion are difficult to handle in pregnancy? Because the volume increases, right? In pregnancy, the volume increases, we all know. Volume increases, so the preload increase. If a valve is stenotic, it can't flow so much of blood, so much of volume. So stenotic lesion become more difficult. Because of the peripheral pooling, the blood coming to the heart is also getting affected. So that way also it will affect the output in stenotic lesion. That's why regurgitant are better tolerated than stenotic lesion. And this is also an exam question. Then the preconception counseling for any maternal disease, like any heart disease, SLE, renal disease, liver disease, whatever in pregnancy, hemoglobinopathies, preconception counseling is very, very important so that you can optimize her health, adjust her medication, which are teratogenic, to stop it or change it to safer medication, like hypertension in pregnancy. If they are already hypertensive, we will make them shift them to the suitable antihypertensive compared to which is unsafe, like ACE inhibitor. So preconception counseling is very, very important for any woman who is aiming for pregnancy with a medical problem so that you can optimize her health. Then comes the optimization of anticoagulants. And this is hot favorite of RCOG, anticoagulation optimization. Believe me, always there is a question from this in exam. How to optimize anticoagulation? Especially in cases of mechanical valve, they are on lifelong anticoagulation. Because mechanical valve is a mechanical valve, it's not part of body. So if they don't give anticoagulation, it will become clot and block. So if you have put an artificial valve for anybody, you have to give them full life anticoagulation. So usually they will be on warfarin. And believe me, I did my MS from KM Hospital, Mumbai in 2008, and it was a tertiary center. So we used to see many patients with mitral stenosis, balloon mitral valvulotomy, coming to us in the beginning to change from warfarin to heparin, and coming at the end to change from heparin to warfarin. So this is very, very important part of management of cardiac disease. If they are on anticoagulation, it has to be adjusted. What is safer, what dose? This is a lot and lots of material actually, but we have to do it in a concise way. One thing we understood is regurgitant lesions are better tolerated. The other thing is right-sided lesions are better tolerated than the left-sided lesion. So it's very important to understand right-sided are better tolerated because that blood is going to the lung, and the left-sided are going to the body. Don't forget this point because they can sometimes give you a long options question where they will give you regurgitant are more tolerated or right-sided are more tolerated. So keep this in mind, like the important point, so that if they give you long options, you can easily rule out which is correct. In exam, sometimes the questions are direct, sometimes it will be all except. So that word is very, very important, except, because if you don't read that, automatically you make it wrong. The risk of adverse effect on the mother and the baby will depend upon, obviously, the severity of disease, how controlled it was before pregnancy is very, very important. If we talk about stenotic valve lesion, either it could be mitral valve stenosis or aortic stenosis, as we are talking more about the left-sided problems because left-sided are more significant. So, which is the most common cause of mitral valve stenosis? They can simply ask you in SBA, which is the most common cause of mitral valve stenosis? And the answer is rheumatic heart disease. If they ask you what is the most common cause of aortic stenosis, that is congenital bicuspid valve. So most common is always important for RCOG. What is most common? You should always keep in mind. Even I would suggest you to, when you're reading, when you're making your notes, just make a small diary about most common also. Like you make a small diary about numbers. And just write it and keep it aside. So whenever you want, you can just brush all the most common thing at one time itself. So it's a good habit of organizing yourself from the beginning so that it becomes easier at the end. Due to reduced ability to increase cardiac output in stenotic lesion, there could be pulmonary venous congestion and pulmonary edema. Mainly in heart disease problem in pregnancy, we are worried about pulmonary edema because pulmonary edema can lead to death, right? So we have to keep a balance of how much fluid to give her to avoid hypotension as well as how much extra fluid to give to avoid edema as well. So this finer balance is what has to be achieved. That's why heart disease become very, very important. And it should be managed under multidisciplinary team, cardiologist, obstetrician, and hematologist, and many other specialty involvement. In regurgitant valve lesion, it usually the cause is almost same like stenotic lesion, typically by rheumatic, congenital, or degenerative disease. Regurgitant are better tolerated. We already discussed about that. What you will do in preconception counseling? Definitely, you want to see how strong her heart is, how much it is already affected, how she will be able to cope in the pregnancy. So any heart disease, what you do, you always want to check the heart. What you do ECG. Then what you do echo. Echo will tell you about how much is the ejection fraction and heart function and everything, volumes of different part of heart. That all help you saying that how strong the patient heart is. And then the exercise tolerance test, because echo is at the rest. So ECG, echo, and then the exercise tolerance test will tell you that how much the body can take the stress, right? How much the body can handle the pregnancy, because pregnancy is also a stress. So exercise tolerance test will tell you about her heart strength. So whenever we are reading a topic, just try to read like understanding, not try to read like memorizing, so that at the end you get something out of it. So what we do for heart disease patient, at least we'll do ECG, echo. Now what extra knowledge we got is we should do exercise tolerance test as well to understand how much they can handle the pressure. What all obstetric complication can happen due to heart disease? Any medical condition in pregnancy can lead to preterm birth, IUGR is what you should keep in mind. So preterm birth could be iatrogenic, could be due to disease. Both ways it is possible. Losses, pregnancy losses can happen. So these all could be related to disease. So preterm IUGR is always the main thing in the maternal medicine. So it can lead to iatrogenic preterm, it can lead to hypertension and postpartum hemorrhages, because they are on anticoagulants and things like that, so have the chance increase. If we see in fetuses, the problem adverse consequences occur in up to 30% of the cases. And it will depend definitely on the severity of disease, how much preterm, IUGR, and the medication effect because of the heart problem. Like labetalol, the beta blockers, which are usually given to the heart disease patient, lead to IUGR. So that's a point you should remember. What you will do in a heart disease patient? Any maternal medicine patient, if you think that there can happen IUGR, you are going to do the serial growth scan from 28 weeks, which will be 4 weekly. This is very important point. The growth scan will be done always from 28 weeks. In our country, we don't care how many scan we do. Sometimes in private, some people do scan quite frequently, but forget your practice. When you are giving this exam, focus on what this exam says, what the guideline says. And if in India or in any other country, if you practice what RCOG says, nobody is going to question. Because you will say that I'm following RCOG guideline. They will never say that you're doing wrong, because it's quite a good practice. So if you follow these guidelines in your clinical practice, nobody can question your integrity, and you can always, in medical legal world, you can always say that what you followed, why you followed, and you are justified in doing that. So that way you are doing safe, you're doing good to your patient and right to your patient. So serial scanning you have to do from 28 weeks, every 4 weeks you have to do. But if it becomes small, SGA, small for gestation, then the monitoring will become more frequent, which will be then followed in the SGA guideline. So it's quite a good feeling actually when you learn new things and write things and you can practice confidently. It's really a good thing, which comes automatically with this exam preparation. So the advantage is not only passing the exam, but improving your clinical skills as well. So serial growth monitoring you will do for all stenotic valvular disease and only symptomatic regurgitant disease. Now, this is the speciality of RCOG. Every word has its importance. Stenotic all, but regurgitant only symptomatic will need 28 weeks onwards. the scans. So they will give you a question that patient is having a regurgitant, mitral regurgitation or aortic regurgitation. She's totally asymptomatic, no problem, everything is going on well. Then she doesn't need growth scan from 28 weeks. Only symptomatic means dyspnea on exertion, NYHA 2, 3, 4, something like that. So be careful about the words. Very, very important in RCOG is the wordplay. If you understand their wordplay, half of the job is done to understand the question well and do the right answer. So if you see the SGA, it's up to 30%. So in cardiac disease, up to 30% can have SGA. If you see in maternal medicine, there will be loads and loads of percentage. So you don't have to memorize each and everything. Just keep a rough idea that approximately 1/3 will have SGA, 1/3 will have adverse consequences. And most of the percentage are like 25 to 30, believe me. 1/3, most of the time it will be 30% IUGR, 30% preterm, so something like that. Practically you can't memorize all, so better not to waste your energy from beginning only in that. Just keep a rough idea in your brain so that you can understand the gravity of situation, that how it affects, how you can talk to your patient in your clinic. And if you imbibe these things in your clinic, in your counseling, it becomes very easy to memorize, basically. So this is the NYHA classification, class 1, 2, 3, 4. So 1 is no limitation, 2 is slight limitation, comfortable at rest, but ordinary physical activity make her uncomfortable. 3 is marked limitation, so less than ordinary activity can make her tired. 4 is unable to carry on physical activity without discomfort and symptom at rest. Why important to understand this? Because the management is different for 3 and 4 compared to 1 and 2. So they are not going to tell you that they may tell you in question that she is NYHA 2 or 3 or 4, but if they don't tell you and they tell you that this description and then you have to understand which NYHA category she is, you should be able to grade it, because accordingly you have to decide. If it is NYHA 3 and 4, you have to do the instrumental delivery. You can't allow her to push because that is a pressure on her heart, so you have to cut short the second stage. So NYHA 3 and 4 is very important to do the instrumental delivery, and that's always an exam question. High blood pressure, if uncontrolled hypertension, you have to cut short the second stage in heart disease. So these are the two indications for instrumental delivery. One is NYHA grading and the second is uncontrolled hypertension. So keep that in mind. Then this is the modified WHO classification of the cardiovascular risk. Very, very important. The same, NYHA 1, 2, 3, 4. And these are the example of the condition. So they will give you this condition, and they will ask you that, will you allow her to continue the pregnancy or not? So you should keep in mind that NYHA 4 is a contraindication sometimes for pregnancy, and you have to tell the women that it's not safe for you to continue. If the ejection fraction is less than 30%, you can offer her termination. If Marfan syndrome with aortic dilatation more than 45, or otherwise bicuspid aortic valve congenital problem with more than 50 mm, there is risk of aortic dissection, so you will tell them to terminate the pregnancy. So what they do, how they form the question is, a woman is having this and this problem, and when you did the echo, this is what you found, her ejection fraction or Marfan syndrome with this is the dilatation or whatsoever. What advice you will give? Continue the pregnancy, terminate the pregnancy, this, that. So always be careful about this category, because here you are going to offer her termination of pregnancy because it's completely contraindicated. Pregnancy contraindicated means she should be on the suitable contraception and shouldn't become pregnant. If she become pregnant, you can offer them termination for severe mitral stenosis, for severe symptomatic aortic stenosis. Now the word symptomatic is very, very important. Don't forget the word play, always. So severe mitral stenosis, severe symptomatic aortic stenosis, ejection fraction less than 30%. And these scenarios are some scenarios where you are going to offer her termination. If pregnancy offer occur, you have to offer her termination. So this is what question they always ask, right? When you are going to offer them termination. Now in category 3, you will not offer them straight away termination, but if they are decreasing, their severity is becoming more and more, and they are not able to cope up with the pregnancy, then you may have to deliver them preterm, like iatrogenic preterm or things like that. So these all will depend on the scenario, but 4 is very, very clear that here you are going to offer her termination. And 1 is very, very clear that no need of doing anything for PDA, for pulmonary stenosis, which are right-sided lesion, for mitral valve prolapse, which is very, very common, and successfully repaired lesion like ASD, BSD repair, PDA repair, you don't have to worry at all. No risk at all. So just you will say that pregnancy is absolutely safe for you and you can go for it. Here you will say it is absolutely unsafe for you and I offer you termination. Now these are the category. 3 is yes, 3 is with difficulty, jerky pregnancy where you have to be very, very careful to treat them. In cases of 2 and 3, it will depend on the individual, how good or bad their heart situation is, which will be done, which you will understand by ECG, echo, and the exercise tolerance test, which we discussed earlier, that preconception, you are going to do these 3 things to understand how strong her heart is, what is her heart condition, how safe the pregnancy will be for her. Sometimes they can simply ask you a question like, operated VSD, ASD, safe, category 1 in the risk, and unoperated will be category 2. So which category it will be? So this table is very, very important for you to understand the gradient, which disease is more severe, which disease is less severe. We discussed about stenotic lesions. So severe lesion will be coming here. We discussed about congenital lesions. So if it is repaired, it will be no risk, but if it is unrepaired, it will be small risk. Then comes a mechanical valve, prosthetic valve, which are wall replacement done for stenotic lesions. So mechanical valve come under grade 3, which is very, very important. We will discuss this in detail when we go further. And then the dilatation of aorta, different sizes will come in different category. Like one category is this, and one category lower will be less severe. So these all things you have to keep in mind. And believe me, earlier there was no source for this, and now this TOG has come and it has made our life simple because everything is there in the one place. Now, if we talk about mitral stenosis classification, this is first we'll talk about mitral stenosis, then aortic stenosis, and then valvular disease. These are 3 highlights of this talk. So mitral valve, if you see mild, moderate, severe, the valve area more than 1.5 is mild, 1 to 1.5 is moderate, and less than 1 will become severe. So in cases of, if they don't write you severe mitral stenosis in the question and they simply write you the valve area is less than 1, you have to understand it's severe mitral stenosis, then you have to offer her termination of pregnancy. Because all the surgeries of mitral valve stenosis or any heart surgery should have been done pre-pregnancy, which is much safer. It avoids the risk of miscarriage, preterm labor, and many other problems. Because in pregnancy, the heart is already hyperdynamic circulation, so it becomes very difficult to operate. So pre-pregnancy optimization is very, very important, right? So that's why they say that severe mitral stenosis, you will offer termination if she becomes pregnant, and mild and moderate, you can manage. Am I making sense? Is everything is clear till now?
Yes, ma'am.
Okay, so thank you. Now, if you talk about mitral stenosis, how it can affect the pregnancy, how much we should be worried about the patient. So mild mitral stenosis, the pregnancy will be very well tolerated. So if they give you valve area is more than 1.5, you should be happy that it's all right. We can deal with this pregnancy well. But if it is moderate or severe, there will be risk of heart failure, right? We are worried about heart failure in heart disease because of the mitral stenosis, left heart stenotic lesion. The circulation will not be enough and then it will lead to pulmonary edema because of the pressure, and then pulmonary edema and then death, right? Heart failure and then death. So we are worried about heart failure. How much will be the heart failure in moderate and severe? Mild, all right, no problem, she can continue. Moderate, the risk of heart failure is 33%, 1/3. Okay, and the severe, the risk of heart failure is half, 50%. So it's quite significant, isn't it? So that's why they will usually be on the beta blockers to decrease the heart rate, control the circulation and everything, so that there is less stress on the heart. If we see overall mortality from mitral stenosis in pregnancy, it's approximately 0 to 3%. This is mortality. while this is heart failure. Heart failure could be heart failure. I don't know if all of you are aware that heart failure can be managed medically, right? So if a patient heart failed, you can always give them some medication and you can maintain it. So it's not like all the heart failure are going to die. They will not die. You can manage it in the hospital setting with careful monitoring. So all will not be having mortality. Overall mortality will not be very high, but still it is significant, 0 to 3% in cases of mitral stenosis in pregnancy. And the predictor will always be how good you have optimized before pregnancy. So if the function class more than equal to 2, if pulmonary artery pressure is more than 30, if severe stenosis, advanced maternal age, then she will have more mortality compared to others. If it is severe stenosis, we already discussed that we will tell her not to become pregnant, and if she become pregnant, we'll offer her termination. What will happen with mitral stenosis? Because there's not enough blood circulating in the body, automatically the placenta will also get less blood. So if less blood in placenta, automatically it will become IUGR. So IUGR in mitral stenosis is up till 30%. As I told you, almost every medical disease, it is approximately 1/3, 25 to 30% for all the risk. So IUGR 30%, prematurity 22, 30%, which could be iatrogenic prematurity also. If a woman heart is failing, if a pregnant woman with heart disease is deteriorating, then baby doesn't matter. Her health is more important. So you'll deliver. Even if the baby, nowadays, the NICUs are so much equipped that they are able to survive the baby even less than 1,000 grams. So prematurity is not a concern. If a mother is not well, Aparna, you can join again, my dear, maybe, because others can see the slide.
Yes, ma'am.
So maybe connection problem at your end, Aparna. Please disconnect and then join again. So you'll be able to then hopefully just go in a stable connection will help, I believe. So what we were discussing is in a heart disease, whenever a woman is getting destabilized or unstable, you always have to treat her. So you will be treating heart failure in pregnancy, keep them admitted, treat them with medication and everything, ICU care and things like that. And at the same time, you have to treat the cause. So if it is mitral stenosis, you have to do the balloon mitral valvulotomy, which is a percutaneous thing. It's an easy thing. But if that doesn't work, then you have to do the open heart surgery, right? Valve replacement. So that's a big thing. That's why they say that optimize her health before pregnancy. See how good her heart is. If she need mitral valvulotomy, do it before pregnancy itself. This is what our goal, to optimize her health. Then comes the aortic stenosis. The commonest cause here is left ventricular outflow obstruction. Commonest cause of aortic stenosis is congenital bicuspid. Like for mitral, it is rheumatic heart disease. For aortic, it is congenital bicuspid heart valve. What happens here is thickening of aortic valve with an antegrade velocity of at least 2 meters per second. If you see in pregnancy, there will be a physiological increase in the echocardiographic gradient. Means when you do echo, we are not the expert in echo and they don't expect us to, but we should understand the basic things like there is a gradient, right, between the two valves. There will be pressure change, there will be ejection fraction and things like that. So they say that physiological increase in gradient is a normal feature in pregnancy. So don't think that it is because of stenosis. Sometimes the physiological increase will also be there. So how you'll optimize her health? Before pregnancy itself, you should do a physician supervised Bruce protocol exercise test. Remember the names. RCOG is always fond of names. Remember the names. Who has developed what things? They want their name to be remembered. So physician supervised Bruce protocol exercise test as well as biomarker NT-proBNP you should do. This is a cardiac biomarker and this is also very commonly, very highlighted way it is given in peripartum cardiomyopathy TOG as well. So these are the two things you have to do before pregnancy to understand what is her risk in pregnancy because of the heart problem. So these are the two things you have to do pre-pregnancy. And if her pro-BNP is normal, you know that her heart is not under stress. And if it is high, you know that she's already under stress and it's a high risk condition for her. So this will give you an idea about counseling her to become pregnant or not. And if to become pregnant, what to expect, right? In aortic stenosis, it's always important to understand it is symptomatic or asymptomatic. Because if it is asymptomatic, even in severe aortic stenosis, you can allow them to become pregnant. That's why in the table we saw that severe symptomatic aortic stenosis, asymptomatic severe can continue the pregnancy. So be clear about this point. So asymptomatic severe, even they can continue the pregnancy. So symptomatic or non-symptomatic is very, very important. If asymptomatic, mild or moderate AS, or even severe asymptomatic, the heart failure risk is low, less than 10%. But if it is symptomatic, it becomes 25%. So if you see in mitral stenosis, we saw that heart failure for moderate and severe is 33% and 50%, while here it is lesser. For aortic, it is lesser. If it is asymptomatic, it's only 10%. For mild, moderate, only 10%, less than 10%. While for symptomatic, it will become 25%, but still it is lesser than mitral stenosis, moderate and severe. So whenever we are reading, we should always compare so that our brain grab a knowledge in a form of story, so that we understand which is more, which is less, which is more important, which is less important, and that helps in memorizing. Now, if you see the guidelines of classification of aortic stenosis, if aortic root dilatation is less than 45 mm, WHO class 3 it comes, but 2 to 3 depending on the individual circumstances. If it is between 45 and 50, it becomes class 3 for sure. If it is more than 50, it becomes class 4 for sure. So this is dilemma. Less than 45 could be class 2, could be class 3. But this will always be class 3 and this will always be class 4. And here you will always tell them against pregnancy and if become pregnant, termination. So what are important points about aortic stenosis? If aortic stenosis is there, there will be risk of preterm and IUGR, which is always there in any maternal condition, and it will be around 20 to 25%. Other important aspect of aortic stenosis is transmission of congenital cardiac defect to the baby. This is very important. This is a very important disease which can be seen in the baby as well because it's genetic. So fetal echo is very, very important. Fetal echo to see if the baby also has aortic stenosis. Nowadays, there is fetal treatment. Maternal fetal medicine is becoming so and so popular. They are doing many things in trying. So it's important for us to understand what's going on with the baby. So fetal echo, if there will be aortic stenosis, you should do to rule out aortic stenosis in the baby, which the chances is around 10%. And this is always an exam question. So as I tell you, TOG, if you read like a story, it's easy to remember and you can correlate well. Now, we saw about stenotic lesion that moderate severe are a problem and mitral is more severe than the aortic. Now we'll talk about regurgitant lesion. In regurgitant lesion, we know that it's well tolerated and regurgitant are better than stenosis. Right-sided are better than left-sided. This we saw in the beginning. In regurgitant lesions, so definitely because it's well tolerated, so mild is of not much of significant, we can ignore that. But if moderate to severe, if they are symptomatic, there's always a chance that they can have a heart failure. What is the chance? It will be up till 25%. So 1 in 4, the same like aortic stenosis. If asymptomatic, less than 10%. If symptomatic, up till 25%. So this is also up till 25%. IUGR will be less here. We saw earlier 25 to 30%. Here it is only 5 to 10%. Because the systemic resistance is low, it's easy for blood to flow and less regurgitation. That's why it's well tolerated. That's why only IUGR will happen. No other OBS complication will increase. Now this is very important. They will give you in question that there is a regurgitant lesion for the mother. Which of the following risks are increased? So only increased risk is IUGR for the baby and for mother cardiac failure. So don't choose preterm, don't choose PPH, hypertension, cesarean birth. No, only IUGR for the baby and only cardiac failure for the mother is a problem we have to cater. This is how they make the question. How it is different. Did you understand well the different situation, which is more to need more your attention, which needs less of your attention, which is more risky, which is less risky. So this is how they formulate the question. How you'd manage? Yes, so a woman came to you with mitral stenosis in pregnancy. How you're going to manage? Definitely, first of all, you have to arrange her antenatal visit. Ideally, you should have done her pre-pregnancy counseling. She came in pregnancy, you will arrange her antenatal visit in the MDT care. You will arrange her medication. You will arrange surgery if needed. Ideally, you shouldn't be needing surgery if you have seen her preconceptionally and optimize her health. So how frequently antenatal cleaning? This is important. So if she's asymptomatic and mild, you will be seeing her once in each trimester, which is enough. But this once in each trimester means the cardiology, the cardiac assessment we are talking about. So cardiac assessment once in each trimester is enough. But if more severe or symptomatic disease, then at least monthly cardiac assessment should be there. What does it mean by cardiac assessment? Cardiac assessment means you will look for her clinical assessment, echocardiography of the heart, and screening for IUGR. So this is what you will do monthly if it is more severe or symptomatic. So monthly echocardiography you have to do. Monthly look for the baby IUGR means monthly scan from 28 weeks. What treatment you will give her? Some of them might be on anticoagulation, which is very important to understand. Whenever, anytime there is some arrhythmia, atrial fibrillation and things like that, there is a chance that it can lead to thrombosis and then dissemination of the emboli, and that's why they need anticoagulation. So when there is MS, there is always a risk of atrial fibrillation and there is always a risk of coagulation. That's why sometimes they need anticoagulation. It will be needed if, now this could be an SV easily, that when a woman with MS will need anticoagulation. They'll need it if there's significant left atrial enlargement, which is more than equal to 60 ml per meter square, or if they are in heart failure. If anybody is in heart failure in pregnancy, definitely there will be stasis, thrombosis, and embolism. So you have to give them anticoagulation. One is the echo finding and one is the clinical finding. In these two situations, you have to give them anticoagulation. And sometimes you have to give them beta blockers if symptoms are not improving. Sometimes if symptoms are not improving with beta blocker as well, you might have to give her diuretics. So regarding diuretics, we all know that we don't want to give diuretics in pregnancy, but yes, if needed, it is safe drug. So if patient is in failure, you can always give her diuretics. We are worried about diuretics because that will lead to less volume in the blood, and then how the baby will get the blood supply. But her health is, as I told you, that is our first priority. So if needed, you can give diuretics for a while in pregnancy. It's not completely contraindicated, is what you have to keep in mind. If you have treated her with beta blocker, diuretics, anticoagulation, still the woman is not improving, then you might have to consider surgery. So when you will do surgery, if women is NYHA class 3, 4, or systolic pulmonary arterial pressure more than equal to 50, means more back pressure. More pulmonary artery pressure is bad. So more than 50 is bad because more back pressure and then it will lead to pulmonary edema. Or class 3, 4 is bad. So you will do what? They will ask you in SBA that which is the intervention of choice. So you will choose percutaneous mitral balloon valvuloplasty is the intervention of choice during pregnancy. This is very, very important. If you can't do this, if her condition is very deteriorating, you can't do this anyways, then the next thing will be bypass. If you do bypass, what is the mortality rate for the baby? It is up to 30%. That's why they say that optimize her health before pregnancy itself, optimize her heart before pregnancy itself. Now, we saw how we are going to manage mitral stenosis. We'll do cardiac assessment every month, every 3 months if they are mild or asymptomatic, or every month if they are severe. We'll give them medication like beta blocker, anticoagulant if needed, if atrial enlargement is there, if cardiac failure is there, and then we may have to give them diuretic if in heart failure, and then we have to decide if they need surgery, if NYHA class 2, 3, or if they are more pulmonary pressure more than equal to 50. So these are the things you have, these are the points you have to remember in management, because these are the number, these are the criteria which they are going to ask you in exam. Then comes the aortic stenosis. How you'll manage aortic stenosis? We saw that aortic stenosis is less severe than mitral stenosis. And if it is symptomatic, then only you're worried. Asymptomatic, even severe, you can handle it. So how you'll follow? At least monthly, but sometimes in severe, you have to do monthly or bi-monthly follow, depending on the symptoms. What treatment? Medical treatment, same like mitral stenosis, beta blocker and, if needed, diuretics in failure. What surgery? Percutaneous valvuloplasty, the same thing, if the symptom persists in spite of medical therapy. What will happen if the woman is having life-threatening symptoms? Then definitely, anytime if you deliver the baby or terminate the pregnancy, then the stress on the heart decreases, so women will improve. So sometimes you have to compromise the baby for the mother health. So if you are working in a tertiary center, it's very easy to understand. You might be seeing the patient in ITU. They will call you for references. The medical team or ITU team will call you because she's pregnant in heart failure, come and assess her and things like that. And then you have to, they will ask you that we want to deliver the baby because it's getting difficult to support her or to improve her condition is not improving in spite of doing everything. Then you have to decide that either you're going to do early delivery or not. If you deliver early, then you have to do it by cesarean section, depending on the gestation, what is her condition. So sometimes you have to plan delivery to help in resuscitation of the mother, is what you have to remember. Am I clear till now before we move forward?
Yes, ma'am.
Okay, great. In cardiac disease, it's always important about anesthesia, right? We have discussed about stenotic lesion, regurgitant lesion, mitral and aortic stenosis. It's all about the circulation, which anesthetic understand better than us because that is what their job is, to optimize the circulation, isn't it? And in UK, there is obstetric anesthetist, which are always there round the clock in the labor ward around. So it's a different practice in UK. That's why the anesthesia role is always, they ask you in the exam, because there is round the clock anesthetist, not like in our setup where the anesthetist is only in OT and we discuss with them. Here anesthetic, 2 to 3 anesthetists are always there available for labor ward patient to take care and discuss. So in anesthesia, again, you have to maintain a balance, not too much fluid to lead to pulmonary edema, not too less fluid to less go to placenta and the baby, right? So this is the main thing, to keep a balance. How they will do this? They can't do some magic or miracle, but yes, they can monitor more vigilantly by doing like arterial line. They can put arterial line to monitor if needed. They can avoid hypertension. If they are giving spinal or epidural, there is always a chance of hypertension. So they have to keep a balance. They have to be more careful when this is heart disease. So avoiding hypertension is one thing they have to deal with. The other thing is the anticoagulation. If they are on therapeutic anticoagulation, you can't give them any anesthesia for 24 hours, right? So that's why it's important that what dose of anticoagulation they are taking. And even in VT guideline, even in many other guidelines, we'll keep talking about when to stop anticoagulation if you're planning for regional anesthesia or anesthesia. So this is always an exam question, how long before you have to stop, when to remove the epidural catheter. These all are already a hot favorite of exam and discussed in VTE guideline. So no need of going in that detail here. Here we are talking about heart disease in pregnancy. So what you will do for anesthesia, if she has received heparin within 24 hours, because you can't give her epidural for pain relief, you can give her remifentanil patient control anesthesia. Now, believe me, this is a new thing, and believe me, I'm 100% sure they can ask you this in SBA because this is not available in every setup in UK. It is only in some centers where they have PCA. This remifentanil PCA, patient control analgesia for labor, is not available in every center. But if you get a patient like this, then you have to refer them before delivery to that center where it is available. So they will ask you that she's on anticoagulation and you can't give her epidural analgesia. So what you will give her for pain relief? And they will give you the option of this remifentanil, PCA, and many others. So you can choose this. That's why they have specifically mentioned this, and this is quite common here, but only available in few centers. So this is an important piece of information. And if somebody is on anticoagulation, therapeutic level of anticoagulation within 24 hours, you can't give them regional anesthesia at all. So if they need cesarean, you have to give them general anesthesia. This is important. You can't give them regional. So what you will do, you can give them general anesthesia. These important piece of information always keep in your mind. If any women taking warfarin and INR is, if her INR is less than 1.5, then you can give them anesthesia. Neuroaxial means the local anesthesia, the regional one. But if their INR is more than 1.5, equal to more than 1.5, you can't give them any regional analgesia is what they say. So these all, whenever they are on anticoagulant, regional analgesia will become a problem, and you'll always involve the anesthetist to decide if we can give, not give, when we can give. If they come in emergency, your only solution is do it under GA. You can't give regional, is what you have to keep in mind. So in anesthesia, mainly they have to maintain the heart rate, they have to avoid the hypotension, they have to take care of fluid management, and they have to manage the anticoagulation cessation. So this is all about the management of heart disease in pregnancy, how you're going to manage their pregnancy, how you'll take anesthesia consideration. Then comes a valve replacement with pregnancy, which is very, very important for exam point of view. There are two types of valve replacement. One is bioprosthetic and one is mechanical. There are some advantage of every valve and disadvantage. So if you see for bioprosthetic valve, it will not require anticoagulation because this is bio body from the animal body, bovine or different animal, they take the tissue and put in your body. So it doesn't need anticoagulation. That's the benefit. And less complications, that's the benefit. But it fails. After a certain time, it fails. So it fails after 10 to 15 years of implantation. That's the problem. If it fails, then you need repeat surgery. So that's the problem. If we talk about mechanical replacement, which is a mechanical artificial valve, the benefit is that it has more long-term option. It doesn't require resurgery, but it will not fail usually. But it requires lifelong anticoagulation. So here it doesn't require anticoagulation, so you can avoid all that side effect of anticoagulation in pregnancy and things like that. But it needs resurgery after 10 to 15 years. Here you don't need resurgery, but it needs lifelong anticoagulation. So patient will always be on warfarin, long-term anticoagulation, and if she becomes pregnant, then you have a lot to do. With mechanical valve, there is 58% chance of event-free pregnancy compared to 79% with bioprosthesis. So if you see for a reproductive age group women, if they choose to have bioprosthesis, that is a good thing because they doesn't need anticoagulation, 79% good outcome, but they have to accept the risk of resurgery later. So these are the things which are to considered in cases of valve replacement in pregnancy. Now, if they are on anticoagulation, there are different kinds of anticoagulation we all know, out of which warfarin and low molecular weight heparin are always the highlights. Out of which warfarin is the safest. Now, please drill it in your brain that warfarin is the safest. Warfarin is the strongest. Warfarin is safest for the mother. It's not only about the baby always. The mother is more important, isn't it? So in valvular heart disease, warfarin is the safest and you want to continue the warfarin. Because if you change it to heparin also, which you feel is an alternative, could be an alternative, but you have to understand that with heparin, there is a chance of thromboembolic complication around 10% for the mother. Though it doesn't go to the baby, doesn't cause any teratogenicity, but at the same time, it makes the mother unsafe around 10%. Right? Now, what happened with warfarin? With warfarin, which is the most effective drug in preventing the complication, but it crosses the placenta and it can lead to teratogenicity, which is 5 to 6%. Now, can anybody tell me what is the speciality of warfarin teratogenicity? When it happens, at what dose it happens? Because it's dependent on the duration and the dose. What time she received, what pregnancy duration she received, and what dose of warfarin she received is going to affect. So anybody has any idea? Because It does has the information in VT guideline as well.
Shweta, it is teratogenic embryogenic phase, 3 to 9 weeks, and if the dose is, I think, more than 5 milligram.
Yes, very correct. If the dose is more than 5 milligram, we are worried, and the duration is 6 to 12 weeks.
Okay.
Okay, so when a woman become pregnant on warfarin, if you want to switch her to heparin, you should do it before 6 weeks, or as soon as she become pregnant within 2 weeks. So 4 weeks pregnant, she will check her pregnancy test is positive. So within 2 weeks, you will change to heparin because you want it before 6 weeks. And then if the dose is more than 5, then the significant risks start. So it's duration and dose dependent. Now, the other thing is, now in this talk, they have mentioned that even if after 12 weeks, there is a problem of facial and neurological problem, even after 12 weeks. But at the same time, you are not the one who can decide for the mother, right? So we have to tell the mother all the risks. We have to involve the MDT, do the discussion that these are your risks. You have risk of teratogenicity, which is not 100%, obviously, it's 5 to 6%. But if we change you to heparin, the risk of thromboembolism complication is around 10%. What do you want? It's not we who will decide, it's the patient who will decide what she wants, what risk she's ready to take. Is she ready to take the risk of teratogenicity, or if she's ready to take the risk of thromboembolic complication? So this is very important to understand, because in our country sometimes we are like, we offer them, do this, do that. But here it is not like that. They will give the patient all the option and they decide what they want. If they decide to change, change. If they don't decide to change, it's all right. They are ready to take the risk. Ultimately, it's their body, right? So this is how the practice in UK is different than the overseas countries. So we should understand their mindset and we should be able to counsel the women accordingly. So that helps us in making the exam easier, like our routine practice. So if you compare warfarin with low molecular weight heparin, they have used the word VKAs, which is vitamin K antagonist for warfarin. It's most effective to prevent complication, but it can cross the placenta. It leads to teratogenicity and can lead to early and late pregnancy losses. Now, how they'll make an SBA, they will say that warfarin can lead to, warfarin pregnancy can lead to. So they will give you teratogenicity, they will give you early and late pregnancy losses. So you should be aware of this also, that it can lead to early and late pregnancy losses. It is not completely only related to baby, but also miscarriages can happen. With low molecular weight heparin, it could be an alternative. It doesn't cross the placenta, but at the same time increase the risk of thromboembolism problem for the mother. So, as well as when you give low molecular weight heparin in pregnancy, changing from warfarin to low molecular weight heparin, you have to give twice daily doses. You have to monitor the anti-TOG level, and you have to maintain a certain level, and you have to give a higher dose, more than 50% dose than the routine prophylaxis for VTE. So these are the things you should keep in mind, because whenever you are changing, what is your goal? What is your aim of anti-TOG level? Usually we don't monitor anti-TOG level with low molecular weight heparin for VTE until illness. It's extreme of ages, renal failure, and things like that. But here, because it's for mechanical valve, you need to reach your target. So you have to monitor her anti-factor TOG level. You have to give her twice daily injections. So it's quite an inconvenience for the women. It's not very convenient treatment. Low molecular weight prophylaxis otherwise is very, very convenient. Doesn't need monitoring and things. But here things differ. So keep this in mind. It's not the best alternative, but it could be an alternative with all these side effects, with all these extra monitoring, twice daily injection, high doses, increased risk of thromboembolic complication for the women. So it's not the safest like it is in VT. It is the safest. Here it is not the safest. Safest is always warfarin, but at the same time, both comes with some of the side effects. So low molecular weight heparin, if you are doing, how you will give subcutaneous injection twice daily, your peak anti-TOG level you want to maintain 0.8 to 1.2. But if non-aortic valve like mitral valve, then you have to go up till 1 to 1.2. Now they can ask you this in SBA, because this is different than routine. Usually it is 0.8 to 1.2, but for non-aortic valve it has to be higher. So mitral, they ask you, then it should be 1 to 1.2. So anything different than routine, you should try to memorize, because that kind of question always asked in exam. As I told you, you have to monitor the levels, you have to monitor anti-TENE level, the dose should be more than 50% higher than the standard weight-based dose, and the risk of TEC is approximately 10% and frequently reported in the first trimester. So these all education you have to give to the women and ask her if she's ready to take all this risk, and only you have to change her to heparin. So what can happen? There are three possibilities: that she can be on warfarin throughout the pregnancy, or she can be on low molecular weight heparin throughout the pregnancy, or you can change her to low molecular weight heparin in first trimester, then warfarin in second and third trimester, and rechange her to again before delivery, right? Because you have started her on low molecular weight heparin at 6 weeks around, and then after first, this is what we used to practice in 2008 in my hospital, that first trimester we used to change them to low molecular weight heparin, then change again to warfarin. So daily we will be doing PTINR and APTT at that time, but now anti-TENE level you have to monitor. So VKA means the warfarin you will give them second and third trimester warfarin. Now any women can't deliver on warfarin, right? Because with warfarin, you can't reverse that immediately. It's a long acting drug. So at the time of delivery, you want to shift her to heparin. So you will shift her to heparin 2 weeks prior to delivery. Switch to twice daily heparin 2 weeks prior to delivery. So in exam, they can ask you any of these, but especially this one, how to change, when to change. And recently in exam, recent recall, they have asked how many weeks prior you are going to change. So it's around 2 weeks before delivery. You want to change them to twice daily, 2 molecular weight heparin. But these all three regime are acceptable. The women can choose anything throughout warfarin and then near delivery change. Throughout heparin is also fine with the risk of thromboembolism, or change to first trimester and then again 2 weeks prior to delivery. So remember all of this. Anything can be asked from, and this is the highlight of this talk basically, how to change the anticoagulation. That is always, bridging of anticoagulation is always a favorite topic of RCOG exams. Am I clear about this? Did everybody get it? How we are going to change? Nobody should deliver on warfarin. Keep this in mind. And if somebody on warfarin suddenly come in labor, then you can't give them any local analgesia, anesthesia. Directly cesarean section under general anesthesia would be a better option. Because the baby can have anticoagulation effect. Baby can have brain hemorrhage while the process of delivery. So anybody on warfarin, you can't allow them to deliver vaginally. You can't give them any regional analgesia, anesthesia. So cesarean under GA would be your only option if somebody comes in labor under warfarin. That's why near you want to change to low molecular weight heparin so that you can give them a trial of delivery. Am I making sense? Are you all with me?
Yes, ma'am.
Okay, great. So intrapartum, so we discussed about how we are going to optimize our health in pregnancy, how we are going to manage the medication, how we'll frequently will monitor anticoagulation management and things like that. Now intrapartum. Intrapartum, the MDT will already plan that will she deliver, will you allow her to deliver vaginally, or it will be a cesarean delivery, or in which setup, and how frequently the monitoring, and everything will be pre-planned. And it will be there with her in her handheld notes, right? So all of the women, ideally you try to deliver them vaginally normally. So normal vaginal delivery is always your aim, but you can't give to all. So it will be possible only for mild to moderate valvular diseases and those who are not on therapeutic anticoagulation. So for them, you can do the normal vaginal delivery. Because severe valvular disease, it will be a risk for the baby as well as the mother, the pushing of the second stage and things like that. So mild to moderate, preferably not on anticoagulation, therapeutic anticoagulation, you can easily give vaginal delivery. Instrumental delivery, you will shorten the second stage if it is severe hypertension or she can't tolerate the pushing. Cesarean delivery, as I told you, if any woman is taking warfarin and come in emergency labor, within 2 weeks, then you have to give her cesarean delivery. You can't deliver her because there will be an anticoagulation effect on the baby as well and risk of intracranial hemorrhage. So definitely they can give you a scenario and ask you how you will deliver her. So if they give you mild, moderate, not an anticoagulation, vaginal delivery. If they give you severe hypertension, instrumental delivery. If they give you on warfarin, came in labor, you will choose cesarean delivery and a GU. Then comes the antibiotic prophylaxis. Back then in 2008, when I did my residency, we used to give antibiotic for all heart disease patient in labor, right? Prophylaxis. But now in this, they have clearly told that no need of giving antibiotic prophylaxis unless the patient has previous history of infective endocarditis. So keep this in mind. This has changed. Earlier it was like for prophylaxis you can give, but now it has changed to only the women who have infective endocarditis history will receive antibiotic, otherwise no need. So this is a very important point to remember. Then comes the third stage management. In heart disease, third stage is very, very important because in third stage, all the blood of placenta suddenly go to the heart, which is around 500 ml of blood. And if heart is weak, it can't handle so much of blood at a time, so much of flow at a time. So third stage is very, very important. If you don't give them diuretics, sometimes they can go in failure. So for all our mitral disease patient at that time, we used to give diuretics. We used to load the Lasix and keep. As soon as they deliver, give them Lasix like that. So diuretics may be required in severely stenotic mitral lesion, which you should keep in mind. But at the same time, you don't want to make them hypotensive as well. So keep a balance is what you need. If there's PPH, don't deprive them of all the fluid. If there is PPH, she's losing blood. If you don't replace the fluid, anyway, she'll go in failure. So you have to keep a balance. So here the anesthetic role comes. They'll put the arterial line, invasive arterial blood pressure monitoring, CVP monitoring, and then accordingly they will manage the patient. Because there is a finer balance to attain, which is not possible without arterial blood pressure monitoring. Then comes the postpartum management. In postpartum management, in third stage, you definitely want to give them oxytocin to avoid PPH, right? So you have to give concentrated oxytocin infusion. And this was quite a popular thing for the heart disease patient. So keep this in mind that concentrated oxytocin you can give, not your routine oxytocin infusion in 500 ml, you put 20 unit or 40 unit and give. You can't give that. So you have to give a concentrated oxytocin infusion. Though it is not mentioned in the talk how to give, so they will not ask you an exam. The good thing about RCOG is they ask you only what they have written in their talk or their guideline. They don't ask you out of the blue the things which are not written. Until there is no guideline for that topic, then it's a vague thing differently. That's a separate thing. But concentrated oxytocin is what we have to use. Usually, what we use here is 50 unit in 50 ml. And then 1 ml per hour, like that. So it's different in different hospital. Everybody practices it differently, but what you have to remember is you have to give concentrated. You can't give the routine one. You can't give ergometrine if there is arrhythmia or a high risk of dissection, because ergometrine increases the blood pressure. So you can't give that in this situation. You can't give carboprost if there is asthma or raised pulmonary artery pressure. So all these contraindication memorize, because you might not be able to give these in case of PPH and heart disease. So you will give concentrated oxytocin, which is safe, recommended. And the other thing will be misoprostol, which is usually safe. Though there could be a little increase in cardiac output because of shivering, but misoprostol is usually safe in heart disease. So these are your two focus to use if a woman have severe PPH with heart disease. Then now she delivered, you manage her labor well done. You have delivered her, you have managed her third stage, very well done. Then again, you have to attain a balance of anticoagulation and hemorrhage. If she has a PPH, how to manage her anticoagulation at the same time. So very, very important to find the balance. So hematologist will be involved. You will be giving them stocking for sure. So these are the things you should keep in mind. Then comes the lactation. They can breastfeed the baby with all the anticoagulants. With warfarin also, they say that though it goes 10% in the baby for the milk, but it's an inactive metabolite and it doesn't affect the baby. So it's safe to breastfeed even with warfarin, even with the parent. So lactation is safe. If mother is not in failure and heart failure and she can feed, she can feed. So lactation is not a contraindication. Heart disease is not a contraindication for lactation is what you have to keep in mind due to medication. If her condition is good, she can feed. Then comes the contraception. No postpartum advice finishes without contraception. So heart disease contraception, always, always, always remember, this is the only situation where vasectomy comes in role. Vasectomy for the male. Why vasectomy is preferred over tubectomy is, tubectomy sometimes the women is not fit for anesthesia. Vasectomy is a simple procedure. Failure rate of vasectomy is much lesser than tubal ligation. That's why vasectomy you will listen most of the time with heart disease patient. If they have a stable partner, vasectomy would be preferred. But yes, if you are doing cesarean, you can do tubectomy as well. So this is what, if they are sure that they don't want any further children, then this is the best choice for them. Then at the same time, at the time of cesarean, you can put Mirana, Copati, that is also acceptable. Otherwise, if you want to put Mirana, Copati later, you have to do it in a hospital setting because of the risk of syncope. So these all we'll discuss in contraception. There is a special topic, special guideline about contraception in heart disease. So these all finer details we'll cover there. But you have to understand that vasectomy's role mainly come here, and you can't give them estrogen because of risk of thrombosis. So OCs you can't give. Only progesterone you can give, but then the failure rate is high. You can give them Mirana and Copati, but then putting require hospital setting and it could be an arrest. So these are the factors you have to consider when you talk to them about contraception in heart disease. So this is all about this talk. Anybody has any doubt? Did you get some points? Do you have some take-home messages? Yes, can I ask few questions if you're clear? Come on, let's practice what we are taking home today in our brain. Even if we remember 4, 5, 10 points, well enough. Shall I ask few questions then?
Yes, ma'am.
Can you all hear me?
Yes, yes, you're audible.
Yes, ma'am.
Okay, very good. So can you tell me that which lesion are well tolerated in pregnancy, regurgitant or stenotic?
Regurgitant.
Regurgitant.
Very good. Which is more tolerated in pregnancy, right-sided or left-sided?
Right side. Right-sided.
In mitral stenosis, when you will tell pregnancy is contraindicated and offer termination.
In severe.
What is severe?
Less
What is
than
the
one.
value for severe?
Less than 1 centimeter square of
Less than 1.
area.
Very good. In aortic stenosis, what's the risk of heart failure?
Mild it is.
In symptomatic, it is 25, and in asymptomatic, less than 10.
Yes, very good. So asymptomatic, mild and moderate, less than 10%, and symptomatic up till 25%. So if symptomatic severe, you will offer them termination of pregnancy. Very good. Then can you give diuretics in pregnancy?
Yes, in mitral stenosis, if the beta blocker is.
Yes, if you can't control with beta blocker, sometimes you can give a diuretics for heart failure for a short while. So it is not the preferred drug, but at the same time contraindicated as well. What is the treatment of choice for mitral valve stenosis if it is not getting controlled with the medical management?
Cutaneous mitral valve balloon valvuloplasty.
Very good. So percutaneous balloon mitral valvulotomy is the preferred treatment, surgical treatment for the women. Now, if we talk about valve, how you are going to change an anticoagulation or will you keep it same, or what you will do? A woman who is having mechanical heart valve, she's on warfarin 7.5 milligram, came to you pregnant and told you what you're going to do.
We have to inform the risk of teratogenicity.
Yes, you will inform the risk of teratogenicity. What options of treatment you will give them?
Switch to gigabyte heparin. If you
Switch to low molecular lipid heparin.
Then after 12 weeks, we can restart the warfarin. Prior to delivery, we can again low molecular weight heparin.
Yes, so there could be either you will tell her either you continue warfarin throughout the pregnancy, which is acceptable with a small risk of teratogenicity in the baby, or you change to heparin in the beginning, 6 to 12 weeks, and at the end, 2 weeks prior to delivery. Or you can change to heparin, and throughout you can take heparin with a small risk, 10%, around 10% risk of thromboembolic complication. So you'll give her all these 3 options and she will choose what she wants. A woman came to you under warfarin in labor, what you will do? How you will deliver her?
Section and then
Cesarean section.
she will be go by cesarean section.
Yes, so cesarean section under GA. Don't forget that.
Under general anesthesia.
Cesarean under spinal, cesarean under epidural, local. So don't be. You can't do anything for heart disease. GA for severe heart disease, GA is safer because GA is more of control of anesthetist. They can control the airways. They can control the patient is under their control. So severe cardiac problem always under GA. They always get operated under GA. Anticoagulation, always GA is safer than spinal or epidural. So keep these things in mind always, even for your clinical practice. So this is all, I believe. I hope you got some clarity about valvular heart disease, and once you read it now, you will feel that there's nothing new to understand and you already know everything and you can memorize well and easily because you know what are the highlights, what's the thing they want to convey to you. So this is how the TOG reading become easier once we go through it, discuss it amongst ourselves. It become very, very easier to memorize. So thank you so much for attending today, and then I'll keep seeing you